Hello everybody, this is Brianna Swartout. Today I will be giving a presentation on intrapartum. This is essentially just the labor portion of pregnancy and birth. Okay, so before we get started, I just wanted to do a quick introduction. I have been a labor and delivery nurse for about 7 years now, and I love labor and delivery. I have also found that I liked the education portion of it. I worked on postpartum for a little bit, and it seemed that when I educated my patients, their fear and anxiety kind of decreased a whole lot. So without further ado, let's get started. Okay, so this is what we're going to be going over today, the influencing factors of labor and the mechanisms of labor. This is nowhere near the whole encompassing process of labor because I would probably need a couple hours in order to discuss all of that. But without further ado, let's get started. Okay, so here are what we refer to as the 5Ps, or the influencing factors of labor and birth. You can read them right there. I would just say that one of the most important ones is the psyche, and a lot of people don't really realize that the psyche can affect labor and birth. Okay, so first is passenger of the 5Ps. This is just the fetus's relationship to mom. One of the number one parts of this that we really want to know is the presenting part. So that can be either cephalic or breech or transverse. As you can see, the first two little diagrams over there on the right, you can either have, so a baby can be cephalic, but you can also have them in face presentation, brow presentation, or regular cephalic presentation. And then you can also have them in breech presentation. So there are a couple different types. There is the frank presentation, which is depicted here, and then there's also footling breech, which is where the feet are pretty much hanging out of the cervix and in the vagina. And then shoulder presentation, that's a little bit more associated with like transverse presentation, I would say. Next is the fetal lie, which is just the relationship of the fetal spine to mom's spine. So you can have this be like transverse, or you can have it parallel with the mom's spine. And then fetal attitude is relationship of the fetal parts to one another. So most babies are in a flex position, like what you see in the breech presentation depicted here. They have their hands and feet really close to their body. Some of them, though, they will have them like extended. And then fetal position of the presenting part. So if you see, so like in the cephalic presentation, you can have a face presentation, brow presentation, or just a straight cephalic where the top of the head is presenting on the cervix. Okay, so and next is the passageway. So this is essentially the anatomy of the mom's pelvis. There is that saying that if a woman has wide hips, then she's got birthing hips, she'll have no problem having a baby. That is not always true, because you want to know like the internal structure. The mid pelvis and the pelvic outlet are what determine if she can have a baby. As you can see over here, there's a diagram of the like 4 different types of pelvises: the android, the gynecoid, the polypelloid, and the anthropoid. Most of these you can have a baby with. The one that has the highest instance of possibly needing a C-section is the platypelloid, only because it's a little bit more flat in shape. As you can see, that like more oval shape, the baby's head isn't able to pass through there. But if you have a big enough oval and the baby's head is small enough, she can still have that baby. So if we don't know the internal structure of her pelvis, we don't always know if she can have a baby. Sometimes this is what makes it so a mom doesn't further dilate and then she has to go back for a C-section. The we don't really know until a woman has her first baby if she can have a baby, if her hips are built for that. And then the second part of the passageway is the cervix, because the baby has to come through the cervix. We always talk about dilation and effacement. So dilation is 0 to 10 centimeters, and then effacement is the actual thinning of the cervix, which we do that in percentages. So the higher the percentage, the thinner the cervix. When the cervix is 100% effaced, it's actually as thin as a piece of paper. And as far as dilation, if you guys want to think about it, 1 centimeter is kind of like the size of a Cheerio, and then 10 centimeters, think of the size of a bagel. Okay, so the second P is powers that influence labor. I want you to think of two different types of forces, the primary and the secondary. Primary essentially just refers to the uterine contractions. So as a woman progresses in her labor and her cervix becomes more effaced and dilates more, her contractions will become stronger. Labor is a positive feedback loop. And what that means is when the presenting part of the baby puts more pressure on the cervix, it causes her body to release prostaglandins and hormones that will then make her uterus contract stronger. And this happens essentially until the delivery of the baby. So things that help this release of hormones and to make the contractions stronger is walking, because you're using gravity to kind of put more pressure on that cervix from the presenting part. You can also tell the mom to use nipple stimulation. Nipple stimulation actually causes a mom's body to release its own form of pitocin, or it's also known as oxytocin. And oxytocin is very, very good at making contractions stronger. And then that'll put more pressure on the cervix, which will then make the uterine contraction stronger, and then more pressure on the cervix. And it's just that positive loop, essentially, until that mom is 10 centimeters and has that baby. The second force is the abdominal muscles of the mom. So when she's pushing, these become very useful, but they're not as useful as contractions. Okay, and the next P is position. When a woman is in labor, we want her to change positions very frequently. This can relieve fatigue. It can increase comfort because sometimes when the baby comes down in the birthing canal, the baby puts pressure on certain areas, and when the mom moves, it causes that baby's head to move. It also helps with the circulation of the mom's blood. So here it says, shift the mom to the left side with a wedge under her right hip. We just really do not want that mom on her back because the baby will suppress the vena cava. And if you think about it, the compression of that vena cava cuts off blood supply, nutrients, and oxygen to the placenta through the uterus. And that placenta is essentially the baby's like lifeline to everything. So we don't want to compress that for too long, because then you will see the baby's heart rate and oxygen reserves affected by that. As far as laboring positions, I always say anything but laying on their back. And you kind of just let the mom, if she doesn't have an epidural, you can let her get in whatever position is more comfortable for you. You just kind of have to coach her through what different things have that can work. And then delivery positions, the two positions here, the lithotomy or semi or complete, and lateral recumbent. Those are the most common, but that does not mean that a mom has to deliver in those positions. I've seen squatting positions, I've seen side lying, I've seen the lithotomy, I've seen them squatting down before when they have a natural labor. So these two are not a must. A mom can deliver in whatever position she feels most comfortable in. Okay, the last P is the psyche. You don't necessarily think about the mental preparedness of patients until you're actually in a labor or a birth. It's been shown that fear can make pain worse. So I always try and make sure that my patients are well educated, whether I do it or they, take a childbirth class, things like that. And I kind of walk them through the process. And so when their contractions and their pain gets worse, they're not just totally thrown for a loop. The feeling of safety, they need to feel safe, like they can trust the nurse and the doctors that they're laboring with. It says here that catecholamines will increase physical signs and symptoms. I've seen this happen plenty of times. These are all of the different hormones that get released, when they're scared, and what it does to the body. Also, different cultures place different interpretations and demands on birth, and I've seen a lot of these examples in all of the births that I've been a part of. Some of them don't want anybody in the room, just like the dad, or I've seen some, like in Hispanic cultures, it's natural for them to have a whole bunch of family members in there. Some Asian cultures or Indian cultures, like the mom will be completely stoic during labor, and because in their culture you're not loud when you're in pain. So, and then other cultures, the loud vocalizations is they believe that actually helps with the birth and the labor process. So when you study the different cultures, just make sure you keep that in the back of your mind, because a patient may not react to pain and show pain the way that you would think they would. Now let's move on to the mechanisms of labor. There's 3 types here. Premonitory signs. This refers to what we refer as lightning. The mom will actually feel and sometimes even see that the baby has dropped into the pelvis. You'll hear, some family members might be like, oh, that baby dropped, your belly's lower. The mom might feel lighter and like she can take a deeper breath. And some moms even experience what's called nesting. So this is like where they're frantically cleaning the house and they're getting everything ready for baby. And it's just like, it's a feeling that they can't really necessarily stop, but then they notice, they're like, oh, well, this must be nesting. Mucus plug and bloody show. So the loss of a mom's mucus plug doesn't necessarily mean she's going into labor, because this can regenerate itself, and some women lose like part of their mucus plug at early on in the 3rd trimester. And I've had a lot of moms call me and be like, I just lost my mucus plug, what should I do? And then I normally always tell them, you have to look for the other signs of labor, which is the start of the early, or quote unquote false labor. So in early labor, their contractions will be very irregular. They're super mild. They don't increase in frequency or duration. So if they're using a contraction monitor, normally they're like every 15 to 20 minutes. We normally say if they're any closer than that, for an hour to 2 hours, then we have them come in and see if there's anything going on. If you suspect that a mom is in early labor, walking will not intensify the uterine contractions. Rest actually helps with the contractions. And during this early phase, the contractions actually do not change the cervix. And then lastly, there is true labor, or real labor. The contractions increase in frequency, strength, and duration. when a mom gets up and walks to try and see if that will relieve it, it doesn't, and it can actually intensify the contractions. And one of the number one definitions of labor is cervical change. So if these contractions continue for a couple hours and her cervix changes, then she is in labor. These contractions do not decrease with rest, and sometimes the discomfort will actually start in their lower back and then wrap around. It's not always in the front. Okay, so this is our summary. So we went over those influencing factors, or the 5 Ps, and the mechanisms of labor. I hope you all enjoyed today's presentation.